Recording in progress.
Hello, everyone, and welcome to today's
Good evening,
session.
everyone. Thanks for joining.
Oh, hold on one second. Okay, everyone, we're just going to give everybody another 5 minutes to log on, get settled in, and then we'll start today's program. Thank you so much for joining us for today. Hello, everyone, and welcome to today's Part 2 review session. My name is Rafael Roman, Chair of the Pharmacy Technician Executive Committee for NYCSHP, and I thank you all for joining us today. We're not going to go into too much minutia in regards to a lot of the stuff that we went over in Part 1 in terms of an intro, but I do want to go over some descriptions and some housekeeping. So, in terms of today, NYCSHP is hosting a medication safety CE that is also geared to providing guidance for pharmacy technician for certification exam. This is a part 2 of a 2-part series. So part 1 was last week, part 2 today. Our learning objectives for today is to review federal requirements for handling and disposal of hazardous and non-hazardous medications, discuss controlled substance schedules, federal requirements, receiving, storage, and ordering, explain risk evaluation and mitigation strategies, REMS, for medications and known harm, and review compounding procedures for non-sterile and sterile products, and lastly, practice with formulas and pharmaceutical calculations. Now, please note for today that today's program is accredited for both pharmacy technicians and pharmacists for a medication safety CE. Everyone is welcome to attend today's program, but only NYCSHP members can claim CE credit. Let me repeat that again. Only NYCSHP members can claim CE credit for today. First-time members are considered pledge members, and their membership is at a reduced cost. So if pharmacy technicians have not been a member just yet, please, by all means, sign up with us. It is a one-time yearly fee for $25, I believe, and we would love to have you join us. Now, without further ado, I'd like to jump into today's program and today's first speaker. Our first speaker today is Matthew Lee. He is going to be our first speaker, and he's our director at large for the Pharmacy Technician Executive Committee, our advisor, our chief, our fantastic leader. Matt, are you on the line with us?
Thanks for the introduction, Rafael. I'm here. Can you hear me?
Yes, I can. You're coming in loud and clear.
Fantastic. Are you pulling up the PowerPoint or should I?
Whatever you prefer, sir.
Yeah. Can you pull it up actually?
Certainly, not a problem.
Cool.
Sharing screen now. Can you see?
Yep.
Excellent.
All right. And can you, let's see. Now I'm going to request host from you, okay?
Approved. Got everything there?
Yeah, I still can't control your screen.
Let me see if I can do that for you. One moment. Make host. Change host. You should be, how about now?
I think you did that, right?
Me.
Me. All right, we'll do this way. Can you guys see my screen?
Yep.
Fantastic. All right. Okay, sorry about that, everybody. So we're going to dive right in. So first, we're going to look at some medications that have narrow therapeutic indices. We're going to talk about some storage considerations. And then lastly, we're going to list some medication indications. That last objective, the medication indications, is probably just going to be self-study, but you'll see what I mean later. So looking up front, medications that have narrow therapeutic indices, basically what it means is there's a small window for effect where if you overshoot, you're going to get toxicity. And if you undershoot, you're not going to get benefit from the medication. So these are medications in which small differences in the dose or the concentration can lead to failure or basically toxicity. So here's a list of the medications with narrow therapeutic indexes. And regardless of the setting that you work in, you'll probably recognize most, if not all, of these drugs already. And the purpose really for you is to understand that these drugs, when you see them, handle them with care. A lot of times, especially if it's a dosing error, they can have some serious consequences. So pharmacists, generally speaking, treat these very carefully. And as technicians, extra vigilance should be had when handling and dealing with these medications. So this is separated by indication. So you have your anti-seizure medications and some of your mood disorder medications. Digoxin, of course, are anticoagulants. Some rheumatoid arthritis or cancer medications like methotrexate are thyroid drugs, antibiotics, and theophylline, which isn't really used too much anymore. But if you do happen to see it, just know that. Switching gears into storage. So depending on the package recommendations and also if drugs are being compounded, they may have different stability and storage requirements. So generally speaking, room temperature is anywhere from 68 to 77 Fahrenheit. Fridge temperature is 36 to 46, and freezers -13 to 14. Most exams, and I believe even most hospitals, just defer to centigrade. But I kept the Fahrenheit just for perspective because I think many of us are familiar with Fahrenheit. And this is important because, once a drug is out of the temperature range, there are definitely some changes that can be seen off, right? So if for anyone who handles IVs directly, if you ever work with a drug called ceftriaxone, you'll notice that once it sits outside the fridge temperature, once it's exposed to light for a prolonged period of time, it starts to turn very yellow and then very orange. And you start to debate to yourself if you should even give it or dispense it. So just know that drug properties can change very quickly. So this should be taken very seriously as well. Beyond use dating and stability. So basically beyond use dating is the expiration date we give to compounded products that you make in-house, whereas expiration dates are really just for when the drug manufacturer creates a drug. So beyond use date is the date at which you should no longer use a sterile product or store it for a patient or transport it at all. And how we assign the beyond use date varies based on what goes into the product. And it's split up into risks. So low risk products are where there's no more than 3 things going into it and it's made in a sterile environment, and that's going to be the most stable. As you add more products, it becomes medium risk. And if any point in time you have non-sterile ingredients, it's high risk. Now, I will say the duration at which the beyond use dates are listed here are just textbook references. Classically, your low risk will have, 48 hours room temperature, 14 days in a fridge, 45 days in a freezer. But it may vary from institution to institution, as some of you may know, depending on your capabilities. For example, if you work in an institution in which the IV room is limited, your probably sometimes the longest you'll have for IV product is 12 hours rather than 24. So that all varies, but for the purpose of the exam, this would be what is expected. This is the classic definition of what room temperature, refrigerator, and freezer beyond use states are. Stability refers to the extent to which a preparation remains the same. So any time in which we say a drug is stable or the stability, that just means the intended properties of the drug are there. And any time in which we deviate from either the storage or the beyond use state, then the stability could be compromised. Drug interactions are a big thing. And that's one of the main things that we as pharmacy do. We monitor, track, and prevent drug interactions from happening. So this table basically highlights the most common drug interactions you'll encounter, and that will probably come up on the exam. And it's basically any concomitant use of 2 or more medications leading to an undesirable adverse effect, or actually could be desirable depending on your setting. So for example, most commonly you hear about statins and grapefruit juice. Thing is, grapefruit juice has these things that decrease the metabolism of statins. So now you have a lot more statin in your body than you're used to, and now you're going to have increased side effects like muscle pains and aches. Commonly, you'll see antibiotics like tetracyclines or fluoroquinolones or the thyroid hormone or bisphosphonates. They interact with multivalent ions. And what's a multivalent ion? It's just basically anything that has a positive charge that you're seeing there, like calcium, magnesium, iron. Those things tend to bind to those drugs and decrease effectiveness. So the classic teaching is, hey, either avoid it altogether or space it out. Nitrates and phosphodiesterase inhibitors, these are things like Viagra. Anytime you hear a commercial about it, you'll probably see don't take nitrates with it, so because it could really drop your blood pressure. ACE inhibitors and potassium, you have increased risk for hyperkalemia or high potassium. And the infamous QTC prolongation. So the more medications that you give together that can increase this QTC interval, increase the risk for a fatal arrhythmia called torsades. So anytime we do it, and sometimes it's inevitable, patients will be on multiple agents, we just need to be cognizant of it, monitor the electrolytes, etc. But this is just an FYI. There are a lot of interactions. These are the classic ones. The last thing I want to provide is some drug resources. So a lot of times when you're doing your self-study and you're trying to look up, what this drug does, what are the brand names, what kind of dosages are normal. There are some various drug resources that we utilize depending on your institution or who you work for. You may have one or more of these references. Lexicon, Micromedics are up to date. They're free at your institution, and depending on your subscription, you may even have access to a mobile app. So that's pretty cool. Make sure you check it out. And classically, this is Lexicon search tool. You'll see that you get IV compatibility, interactions, drug IDs. It's very helpful, and I'm biased because I trained with Lexicon, and I think it's the most straightforward. So when it comes to studying for the test, let's say you're not sure about what category a drug is in. Well, I would refer you to the pharmacologic category section in the monograph. So you type in a drug, type in amlodipine, and boom, right there in this green box here, you can see the categories. You can click on it. Let's say I clicked on calcium channel blocker. It will then list all calcium channel blockers and any combination with the calcium channel blocker. So very cool if you want to see or correlate, what other drugs are in this class or what other drugs work similarly. So I think it's a great resource. And most drug databases have this capability, but again, LexiComp is what I'm showing. If you have up to date, you basically have LexiComp because the drug information is actually pulled into up to date. So check that out. And the last thing I want to leave you with is some references for self-study. So a lot of, brand generics and pharmacologic categories for the exam, unfortunately, is going to be memorization study, So what we provided in the slide deck, which you'll receive, are common breakdowns of pharmacologic classes. So for example, I have 5 here: antidepressants, inhaled corticosteroids, diuretics, all these other things. So they're all at the end in an appendix portion where you self-study, and we'll highlight, the different types of medications and their dosage form. So, because it varies depending on your setting, you may not see the injectables too often, but just know that they exist. So that's for your reference at the end to self-study. And that's it for my section for medications. Stop sharing here.
Thank you so much, Matt. We appreciate that. Great work. Ladies and gentlemen, especially when it comes to what Matt was just going over, we really, truly encourage you to look over those self-study tools that Matt had provided, flashcards or what's going to save you when it comes to this, when it comes to brands and generics. The PTCE and the NHA exam really go into this very heavy. So we strongly encourage everybody to truly just flashcards. Do not lose a point just because you weren't able to memorize a brand or generic. Trust me, it is essential. So thank you so much, Matt, for that. Next is me. Matt, can you just make me the host?
Sir, 1 second.
Got it. Thank you. Okay, let me get my screen all set for you. It's bigger. And slideshow. Current slide. Okay, ladies and gentlemen, so my section, I won't lie, is not the most, how can I put this, entertaining section of them all, but it's on federal requirements. It's about 12.5% of the actual exam itself. Now, I took on this task of doing federal requirements because this was the one section of the PTCE that when I first took it, I actually failed because I didn't know the laws properly. So I strongly encourage that you take a look at these slides. I'm going to go through them. For those of you that are tuning into us that happen to work in the retail side, this is pretty self-explanatory. You pretty much know this inside and out. For those of us that are working more on the clinical side or the hospital or the institutions, these don't come readily available to us because we don't necessarily have to worry about this. Our pharmacists take the heavy lifting of worrying about laws, or our legal departments. So let's dive in. So what we're going to be reviewing today is federal requirements for controlled substances prescriptions, new, and particularly when it comes to new refills and transfers, and DEA controlled substance schedules. We're going to talk about federal requirements for the DEA and FDA for controlled substances. That means including receiving, storage, ordering, labeling, reverse distribution, take-back programs, and loss or theft of any type of product. And lastly, FDA recalls when it comes to medications, devices, supplies, supplements, and classifications. So let's talk about controlled substances. Controlled substances are medications that carry a high risk for abuse and misuse. The regulatory body that actually focuses on controlled substances is the DEA, or the Drug Enforcement Agency. Now, they set standards when it comes to storage conditions, so designated areas such as a vault or locked cabinet for certain controlled medications are segregated to maintain accurate inventory, potential for diversion, and unethical practices. They also are key when it comes to tracking movement. The DEA regulates all movements and ensures that the process is traceable for proper handling and minimize any potential for diversion or unethical practices. So this is from manufacturer to pharmacy, from pharmacy to patient. So they're tracking every step of the way. So let's go over the schedules of drugs. So it starts with Schedule 1 all the way up to Schedule 5. So in terms of Schedule 1, has extremely high potential for abuse. It is not accepted medicinal use in the United States, and examples of this would be heroin or cocaine. Next, we have Schedule 2, which has a high abuse potential, and is described as a severe psychological or physical dependency. And we see this commonly when it comes to oxycodone or Adderall. The next class would be Class 3, which has the moderate abuse potential and is described as risk for dependency. We see this when it comes to ketamine and Suboxone. Next, we have the fourth category, Schedule 4, which has a low potential for abuse. It does also have risk dependency, but we see this with alprazolam and zolpidem. And last but not least is Schedule 5. This has the minimal abuse potential and the risk for dependency, and it contains limited amounts of narcotics. We see this commonly with codeine-containing cough syrups. So Robitussin, AC, we see that come, and then pregabalin. So let's talk about C2 medications and filling restrictions. When it comes to C2 medications, they can be sent electronically, can be handwritten on a secure prescription, and faxes are only acceptable for hospice or long-term care. When it comes to when a doctor phones in the prescription or any type of prescriber phones in the prescription, it's limited for 72 hours, depending on the jurisdiction. And it must be followed up with an electronic or hard copy. So a doctor can't just simply call it in. He or she has to provide, or they have to provide an electronic or hard copy for it. The expiration date or restrictions. Now, state regulations typically have within 30 days of a written date from the time you fill the prescription. And federal regulations do not suggest a specific time limit. So it varies from state to state. Whenever you think about the PDCE and studying for this, think of the federal government, not your local government. Granted, it's always the strictest of the two in practice, but for the sake of the PDCE, think of federal regulations. So I threw that on there just so you all know. In terms of refills, there is no refills when it comes to C2 medication filling. Partial fills are a little bit different. If a patient insurance has specific quantity limits or a patient doesn't want to fill the entire quantity, the remaining balance is forfeited and cannot be refilled. So if you have a prescription that's about 20 tablets of a C2 medication, and I only want to take 10, once I request that 10, I can never get those other remaining 10 back. It's only 10 to be filled, and that is it. We can also do partial refills when it comes to hospice patients that are eligible for hospice patients are eligible for partial fills and increments. And prescriptions expire in 60 days from the written date. Now, in terms of transferring, if I wanted to take the prescription is at my local Walgreens and I want to pick it up at my mom and pop's in a different area, I cannot transfer that prescription. There is no transfers when it comes to C2 medications. Next, we'll talk about controlled substance 3 through 5 and their filling restrictions. When it comes to the 3 through 5, prescribers can send it electronically, handwritten, faxed, or phone. In terms of expiration date and restrictions, it's 6 months from the date written and a limited of 90-day supply max per fill. In terms of refills, yes, they can be refilled, but limited to a max of 5 refills or 6 months. In terms of transfers, yes, it can be transferred between pharmacies one time only, unless pharmacies share an online real-time database. So using the example I said before, I have my Walgreens here, and then somewhere else I have my mom and pops. If I wanted to transfer my C4 medication, for instance, I can transfer it once and one time alone. But if I have my Walgreens here in Manhattan and I want to go to my Walgreens in upstate New York and they share the same system, I can transfer the drug at any time I want because they share the same online system. So that is when it comes to filling restrictions with controlled substance 3 through 5. Now, just an FYI when filling controlled substances, and particularly when it comes to refills, controlled substances cannot be filled early. At most, 1 to 2 days are acceptable. When it comes to transfers, all transfers must be between 2 pharmacists. After transfer, the prescription should be voided by the original pharmacy after transfer, and a notation that is transferred prescription should be written by the current pharmacy. When it comes to C3s through 5s, indicated by law for refill purposes only, not initial fills, non-transferable. Information needed for a transfer is the original prescription date and dispensing date, number of refills remaining, the name of the transferring pharmacist, the DEA number, name, and address of the transferring pharmacy. Now let's talk about ordering controlled substances. When it comes to ordering C2 medications, it's not as simple as ordering something on Amazon. It's a heck of a lot more complicated. When it comes to ordering controlled substances, when it comes to C2s, it must be ordered on a Dea222 form. Keep that in the back of your mind, ladies and gentlemen. When it comes to C2s, think 222. That is how you order medications. The PDCE will throw that type of question on there for sure. When it comes to Dea222 form, it is specific to Schedule II drugs and must be completed in triplicate and can be handwritten or typed. Now, this triplicate form comes in 3 different forms. The top copy is for the supplier. The middle copy is sent to the DEA, because keep in mind, they're tracking. And the bottom copy is sent back to the purchaser. The Dea222 is valid for 60 days once filled out, and the max of 10 different medications on one form signed by the pharmacist who's registered with the DEA. Or a controlled substance ordering system, or the CSOS, can be used in place of the Dea222 form for ordering controlled substance 2s. Pharmacies must meet specific electronic requirements to ensure digital security when using the CSOS, and largely replace paper DEAs due to Dea222 forms due to convenience and ease of use. Now, as of October 2019, the DEA has ruled in favor of a single copy Dea222 form to replace previous triplicate format, and the triplicate will be obsolete soon. So that's something to keep in the back of the mind for practice. Now, the one thing, and this is always the thing that I want to scream at the PTCE, but is very, very important for our practice, is the DEA verification, because there's this big giant formula to try to verify DEA, but this is something that can definitely be asked on the exam. So when it comes to the DEA verification, DEA numbers consist of 2 letters followed by 7 numbers. The first letter indicates the type of DEA registrant, and the second letter is the first letter of the prescriber's last name. Yes, I know that's a tongue twister and it sounded a little confusing. So just to repeat, the first letter identifies the type of DEA registrant, and the second letter is the first letter of the prescriber's last name. To verify, follow the following steps. Add the first, third, and fifth numbers together, the odd numbers basically, and add them up and you have that one sum. Then add the second, fourth, and sixth number together and basically the evens, and then times that by 2, which equals sum number 2. Now, if you add sum 1 and sum 2, you get the grand sum. The second digit of the grand sum is the same as the last digit of the prescriber's DEA number, and then you have your verification. Now, nowadays, we also have the computer system that verifies it. But in the case the computer system is down and this is your last ditch effort to try to verify, at least you have the formula here. Definitely practice up on some of these. A lot of resources are available online for this. Now let's switch gears and talk about the FDA, or the Food and Drug Administration. The FDA, or the Food and Drug Administration, is responsible for regulating the safety and efficacy of medical devices, drugs, and biologics. They're responsible for approval of all medications before it can be put on the market, and regulates the manufacturing, labeling, dispensing, and post-market surveillance. So the FDA is in charge of black box warnings. Now, a black box warning is a warning aimed to alert healthcare providers and consumers of serious potential adverse effects of life-threatening risks. An example of a black box warning drugs is opioid analgesics. They contain a black box warning alerting the product's high risk of abuse, misuse, and addiction, in addition to potential for life-threatening respiratory depression. Now, when it comes to FDA labeling requirements, the pharmacy labeling of a controlled substance must be compliant with the following federal regulations. So a prescription label must have a fill date, pharmacy's name and address, prescription number, patient name, prescribing practitioner, the drug name, strength, dose form, quantity, and number of refills, if it's a C3 or 5. And the directions for use and any applicable cautionary verbiage. The FDA requires that the following warning must be present on the label. Caution, federal law prohibits the transfer of this drug to any person other than the patient for whom it was prescribed. So that must be on every prescription bottle when it being dispensed for a patient when it comes to any controlled substance. When it comes to dispensing controlled substances, a prescription is only valid and can be dispensed if it is written for a legit medical purpose under the useful scope of practice of a prescribing practitioner. Medication must be legally dispensed to the patient or a member of their household. There is no federal quantity limit on controlled prescriptions. State law, depending on jurisdiction, typically limits C2 dispensing to a 30-day supply and C3 through 5 to a 90-day supply. Now, when it comes to reverse distribution or the Dea41 form, reverse distribution occurs when a pharmacy sends outdated, unusable drug product back to the drug manufacturer or other authorized distributor for processing or disposal. So these are basically medications that are expired, are broken, or whatever the case may be, and you want to return those back. So in order to do that, you have to fill out a Dea41. So you have to think about that for a moment. Also, this may occur when drugs are returned by patients or the drugs are expired. So the Dea41 form is outdated, damaged, or unwanted controlled substances may be destroyed under the authorization of the DEA. So if you get authorization to destroy the drug, you also will have to fill this out. This form is used to destroy the medications. The form must contain the following information: dates, locations, and method of destruction, the NDC number, name, strength, dosage form, and quantity of the medications being destroyed, and signatures of 2 witnesses of the destruction, and it should be employees. When it comes to loss and theft, there's the DEA Form 106 form. In the event of lost or stolen controlled substance 2 through 5 medications, the DEA and local law enforcement must be notified immediately. Pharmacists must then fill out a DEA 106 form that details the medication's involvement in the theft. The original form is sent to the DEA, and a copy of the form is kept by the pharmacy for pharmacy records. Only a significant loss of controlled substance is required for the DEA 106 forms. Small liquid spills or broken tablets do not need to have this report. But if you happen to walk into your pharmacy one day and all of a sudden your entire C2 safe is gone, you best believe you're going to have to fill out a DEA 106 form and call the police ASAP. Now let's switch gears and talk about drug recalls. Pharmacies must comply with all drug and product recalls and responsible for keeping accurate records to aid in the safety of patients that might have been affected. Various reasons for a drug or product recall would be problems with the dosage or form, adverse reactions related to specific medications. Pharmacists need to contact all patients who might have been affected and reconcile the need for the recall. All recall records should be maintained similar to prescriptions. So there's 3 different classes when it comes to recalls. There's class 1, which is the most severe type of recall and involves medications that is likely to cause adverse effects and even death. One example of this would be one drug is labeled as another drug. Class 2 occurs when medications may cause temporary adverse health effects that are reversible or if there is a small risk of serious adverse effects. We saw this very commonly with the Johnson & Johnson recall, or just recently when it comes to the COVID vaccine. Next is the class 3. It is the least severe and not likely to cause a patient to have adverse effects. An example of this was in 2017, where glipizide ER tablets were recalled due to failed limits for water containment during stability testing. Now, drug recalls target 3 different types of spectrums. You have medications, devices, supplies, and supplements. When it comes to medications, recalls protect the public from imperfect or potential dangerous medications that are discovered after the medication reaches the US market. Common reasons would be that a product contamination, presence of impurities, product mislabeling, and adverse effects. When it comes to devices, devices can become defective or a health hazard, which would warrant a product recall. And common reasons for this would be, or common medical devices that would be recalled would be insulin pumps, glucose meters, infusion pumps, glucose test strips, and cardiac pacemakers. When it comes to supplies, recalled by the FDA or generally they are recalled by the FDA or voluntarily by medical supply manufacturers due to faulty components. Some common medical supplies would be needles, syringes, surgical gloves, or sterile saline. And last but not least is supplements, recalled from time to time that's supposed to say time. Clearly I was still half awake when I did this slide. Recalled from time to time for various health reasons, and common reasons are contamination, presence of undeclared ingredients, super or subpotency, and product mislabeling. Now, in terms of laws that we need to memorize, I need to keep this lecture as brief as possible, but I'm listing these here. Definitely know these laws and memorize them as best as possible. Now, keep in mind, don't limit yourself to just these laws. Many websites are available online do provide, if you just Google search PTCE and laws, literally they will show you the most up-to-date pharmacy laws that the PTCE might ask you. NHA also asks a lot of law questions that are very similar to the PTCE. So please don't lose points on this. Study up on them. No different than than what Matt was showing us before when it comes to the drugs. Laws are also important too. All you need to know is just simple things. Remember, just simple mnemonics could help as well. So please study up on these. Do not lose a little point on these. We want you certified ASAP. These are my references for today. And now I'm going to turn over our lecture today with the amazing Dr. Sarah Amin. Sarah, are you on the line with us? Not yet, maybe?
Yes, hello, can you hear me?
Yes, hey Sarah, how are you?
I'm good. Okay, so let me, can I share my screen?
Yep, I'll give you, I'm going to send it to, I'm going to make you a host right now. Where'd it go? Okay, stop sharing. Sarah, and I'm going to make you a host. Change host. You have the floor, Sarah.
Perfect. Let me see if it works. Okay. So perfect. Okay. So I will be going over order entry and processing. It's this portion of the exam is basically almost a quarter of the exam. And it includes non-sterile compounding, such as mixtures, ointments, liquids, emulsions, suppositories, and enemas. Now, with the different compounds, the procedure varies, but this is the general procedure throughout all the compounds. So first we get the order, we create a formula. We see what products we need, what amount of ingredients we need, and we do all the calculations to see how much we need of each product. Then we wash our hands and obtain any hardware supplies that are needed. So that would be your graduated cylinder, your scales to measure out the active ingredient, things like that. Then we weigh and measure the ingredients, combine the ingredients, and then document and label the product. So a mixture is at least two substances, either two liquids, a solid and liquid, or two solids. It's basically an active compound, an active and an inactive ingredient that make up a compound. Hold on, okay. So the example here is the liquid mixture. We have Magic Mouthwash. It's lidocaine 2% liquid and acid, like a Malox or something, and diphenhydramine in a 1:1:1 ratio. So all this means is that if you have 10 mLs of lidocaine 2%, then you should have 10 mLs of your liquid and acid, and then 10 mLs of your diphenhydramine. to give you yield a 30 ml solution of final product. So the next one is ointments. Ointments are a topical medication preparation. You have ointments or creams. So ointments are water in oil mixture where the base is more oil, it's more viscous, whereas a cream is not as viscous, it's not as thick, and that would be opposite. That would be an oil and water mixture. So that last one, that last word is going to be what the base is, what basically like, 50 or what 51% of the product entails. And in this picture, you see mixing through spatulation. They're using a spatula and they're trying to incorporate the ingredients together. And a method using geometric dilution would help with mixing either an ointment or a cream to make the compound. So geometric dilution is basically you take small equal parts of each ingredient and you mix them together one at a time to obtain a uniform mixture, and then you store it in a tube or a jar. Now for liquids, you have a solute, which is the active drug, and then you have the solvent, which is the liquid component, and that's going to be used to administer the active medication, the active drug. The key here is to make sure that it is a uniform mixture. It's dispersed uniformly throughout the liquid. Now, an emulsion is when there's two liquids, but they're immiscible. They don't mix together. There's a discontinuous phase and it's dispersed through a continuous phase. The best example here would be salad dressing. So if you have a vinegar base and then you see those little bubbles of oil in it, and then you shake the salad dressing, it becomes a homogeneous mixture. And it's now these two components they can mix once you agitate it, once you shake it. Now for suppositories and enemas, suppositories are a solid formulation. They could be either for rectal or vaginal administration. It's basically an active medication suspended in a base, and the base is essentially something that you need to help the medication get to where it needs to be. And this is usually done through either hand rolling. Here in this picture, you have compression molding. You can also have fusion molding. And enemas are also they could be for rectal administration as well, but it's more of a solution formulation, not a solid formulation. Now, when you have these compounds, you saw those compounds, they're expressed in percentage strengths. So they can either be weight by weight percent, which is grams of ingredient over 100 grams of total product, weight by volume by volume percent, which is milliliters of ingredient over 100 mLs of total product, or weight by volume percent, which is grams of ingredient over 100 milliliters of total product. So the key here is to focus on the units. It's percent, so it's 100, but it's kind of counterintuitive, like it doesn't, it's hard to realize that, hey, grams of ingredient over milliliters, not grams over grams or milliliters over milliliters. So that's where it could be kind of tricky. So in terms of metric conversions, the easiest way to kind of memorize this would be through the mnemonic, King Henry died by drinking chocolate milk. So in that mnemonic, the B stands for the base unit. You can have grams, liters, meters, and the other words are kind of the prefixes that, that you could use to kind of see where you will move your decimal place, either to the right or the left. So let's say if you have 20 milligrams, I have a trailing zero just for, to illustrate the decimal place. So you have 20 milligrams, you want to change it over to grams. So you're just going to bring the decimal place over between each word to get to that base unit of just grams without a prefix. So the 20 milligrams becomes 2 centigrams, which becomes 0.2 decigrams, which becomes 0.02 grams. So 20 milligrams is equal to 0.02 grams. So the best way to now go through all of this is through, a problem. So what is the final weight by volume percentage strength in 20 milligrams of active drug powder dissolved in 50 mLs of liquid? So you can either use that mnemonic, or you can just use the conversion factor and know that you divide by 1,000 to get 0.02 grams. So if 0.02 grams over 50 mLs, if 0.02 grams in 50 mLs, we want to know how many grams are in 100 mLs. And then we cross multiply 100 times 0.02 grams is equal to 50x. And then we just divide and get 2 over 50 mLs equals 0.04 grams in 100 mLs. So it's expressed as 0.04% weight by volume. So over there we used a ratio, a relative value between two numbers. So like we used with the magic mouthwash as well, 1 to 1, that's a ratio. So, but a proportion, you'll need ratios and proportions for the calculations, but a proportion is the equality of two ratios. So another calculation method would be dimensional analysis, or the factor label method. This converts the units of measure through a conversion factor. Conversion factor is just the relationship between two numbers, and you'll need that factor to convert from one unit to the other. Now you can memorize this formula, unit given times unit wanted over unit given, or you can just follow the units. Make sure that they cancel each other out. If one unit is on top and one unit is on the bottom, they can cancel each other out. And if you focus on that and just follow the units, you can also figure out how you can convert units of measure. So how many centimeters are in 6 inches? So we have unit given times unit wanted over unit given, and then we have the conversion factor. 1 inch equals 2.54 centimeters. So we can follow the units and just forget about the numbers right now. We have just follow the units. You need to your answer has to be in centimeters. So we're going to put that on top. And then we have to cancel out those inches. So in 1 inch, one side has to be on the top and one side has to be on the bottom so that the inches can cancel each other out. So then now you plug in the numbers, 6 inches times 2.54 centimeters divided by 1 inch. And then because just for illustration purposes, I put the 1 underneath the 6 inches. So now you can see that the inches is on top, the inches are on top, and then the other inches are on the bottom, and they can cancel each other out, and you can get your answer in centimeters now. 6 times 2.54 equals 15.24 centimeters. So 6 inches is equal to 15.24 centimeters. Now, these are some of the conversion factors that you would have to memorize for the exam. The next method is the next calculation method is the allegation method. Now, this has several parts. It seems overwhelming, but if you follow it slowly, follow it through, it's not as confusing as it seems. Even the wording sounds calculates the proportion of two solutions of different concentrations needed to produce a final solution of a desired concentration. So you have this little tic-tac-toe board here. The H represents the higher concentration, the L represents the lower concentration, and the P represents the desired product strength. So if you plug it into that little tic-tac-toe board, and then you do P, and then you just follow it along for the top portion, P minus L, and then the bottom portion would be the same thing, but opposite, H minus P. Now, the P minus L, it doesn't follow through, right? It should be L minus P, but then if you do that, you'd get a negative number. So if that happens, know that you did it the opposite way. You should not be getting a negative number. So let's plug it in with a formula. How would you make 700 mLs of a 30% solution if you have a 60% solution and a 25% solution? So we have our tic-tac-toe board here. Let's add the numbers. The desired product strength is 30 mLs. We have the higher concentration, which is 60%, and then the lower concentration, which is 25%. Now we just do P minus L, which is 5, and 60 minus 30, which is 30. So now that we have all the numbers filled out in our little chart, what do we do with these numbers? The top number represents the number of parts of the higher solution, right? Because it's on top, just follow the line. 60 and then 5. So 5 parts of the 60% solution. The number on the bottom represents the number of parts of the lower solution. So 30 parts of the 25% solution. Now, in order to get your answer, you need to add all the parts together. So 30 parts of 25% plus 5 parts of 60% equals 35 total parts. If my method gave me another number, like let's say it's at 60 parts and 5 parts, then I would add those numbers and get 65 parts. So it's just based on whatever you're getting from that tic-tac-toe board. Now I'm going back to my question. It says to get my final product. My final product, the quantity they want is 700 mLs of 30% solution. So then I'll do 700 mLs divided by 35 parts, which will give you 20 mLs per part. So now plug it into the formula from the top. If you have 5 parts of a 60% solution and each part is 20 mLs, you do 5 parts times 20 mLs gives you 100 mLs. Then you do that for the 25% solution. Each part is 20 mLs times 30 parts gives you a total of 600 mLs. So you need 600 mLs of the 25% solution and 60% of the 100 ml solution. So that will give you your final product, which is 30% of a 700 mLs of a 30% solution. So another thing that you need to know for the exam would have to be your Sig Codes. When you read a prescription, they have a lot of abbreviations or Sig Codes that you'd have to memorize. So here we have QD is once daily, QOD is every other day, and QOW is every other week. Q just represents every. So if it's like, it says Q4 hours, every 4 hours. If it's Q6 hours, it's every 6 hours. So that's pretty interchangeable. Of note, in the hospital setting, QD, QOD, QID, those are, kind of don't use those anymore because of the high risk of medication errors. Also, routes of administration is something that we'd have to memorize. Also, sometimes the numbers are expressed in Roman numerals. So these go by a little bit, the rules here are a little bit different. Roman numerals can be repeated up to 3 times. If they're repeated up to 3 times, the values are added together. So if I say XX, it would be X plus X, which equals 20. The exception to this would be the V. V equals 5, and it can't be repeated, because if it's repeated, if I do VV, that's 10. I already have X, which is 10, so it's a little redundant. That's why that's one of the exceptions to the rule. Also, values that are added together, if a larger number is followed by a smaller number, then you add those numbers together. if a smaller number is followed by a larger number, then you subtract those values. So if I have VI, that's 5 plus 1, that will give you 6. If I put that in front, it would be 5 minus 1, which equals 4. And these are some other additional abbreviations that would be that you could see on a prescription or that you would need to know as a technician. And once again, the same thing, it says Q every, some of these are kind of self-explanatory, but some of these would require a little bit more knowledge, like OS would be left eye, OD would be right eye, and OU would be both eyes. But this is something that would have to be memorized prior to the exam. And that's about it. Thanks, guys.
Thank you so much, Sarah. We really do appreciate you doing this lecture, especially when it comes to math. I know I am no mathematician, but you explained everything flawlessly and so descript. I loved it from start to finish. So thank you, thank you, thank you, thank you, thank you. So ladies and gentlemen, we are coming up to the 7 o'clock hour. We still have one speaker left, but despite the fact of having one speaker left, we're going to be dropping the codes for our pharmacists and pharmacy technicians to claim credit. Again, only pharmacy NYCSHP members can claim credit, but if you are not a member, you can certainly sign up, get the codes a little bit later. It's only if you're a pharmacy technician in the audience today, that it's about a $25 sign-up fee. Literally, it's 1 year that you get to have amazing, entertaining CEs by other great speakers besides myself. I'd like to say Matt is also a fantastic speaker, and we also have the other Matt that is joining us today for his lecture. Hello, Matthew. How are you?
I'm good, Roman. How are you?
I'm doing great. You know how it is. It's a Thursday night, enjoying my pharmacy fun time. So I'm doing marvelous. Would you like me to advance your slides, or would you want to advance your slides for yourself, sir?
If you can, please.
Not a problem. I'll get that all set up for you. One moment, please. First, let me just drop the codes. So the codes for today for pharmacists, CE codes would be RISK. That's R-I-S-K. For pharmacy technicians, it is going to be hazard. Again, for pharmacists, that is risk. For pharmacy technicians, it will be hazard. H-A-Z-A-R-D. But don't go anywhere just yet. We have another great lecture for, pharmacist risks, pharmacy technician hazard. Thank you, Krista, for updating that. Okay, Matt, let me get you all set up. Share screen. Oh, Sarah, if you're still on the line, can you make me the host again?
Yeah, hold on. Let me do that.
Thank you.
Okay, did it work?
No, not yet. Oh, wait, I think I got it. Yep, I got it. Thank you. Okay, play from. Matt, can you see my screen?
Yes.
Excellent. So just tell me when to advance and I'll advance the slides for you. You may begin whenever you'd like, sir.
So my topics are drug administration and disposal and recalls. Okay, Roman. So in terms of different types of drug administration, this is an oral syringe. It's not for injection. It's not recommended that you use an injectable syringe for oral use. To cause medication errors. You don't want them injecting an antibiotic suspension into a patient. Okay, Roman. Okay, this is an injectable syringe used for either vaccines or any IM injection or IV preparation. Okay, these are different examples of unit dose packaging for capsules and tablets. Those are those pictures were produced by commercially, not in-house hospital unit dosing. Okay, Roman. Okay, this is another example of drug administration for respiratory inhalers is using the spacer. It helps to break up the drug particles and increase absorption in the lung, making the drug more effective. Okay, Roman. Different examples of diabetes supplies. Most of these are over the counter. Test strips, lancets, glucometers. Syringes are by prescription. Okay. So next I'm going to be talking about lot numbers, expiration dating, and NDC numbers. Okay. So this is a typical label that you would see on a prescription bottle from the manufacturer. For whatever reason, this label does not have a lot number or batch number and expiration date on it. But in general, the label has the drug strength, the quantity, manufacturer, storage conditions, how it should be dispensed. The warning is standard on all drugs to keep out of reach of children. And okay, so the lot number, which is missing on this label, okay, go ahead, Roman, is used for mainly identification purposes in case there is a recall. Also is used for a date when it was packed or repacked, and inventory control in the pharmacy itself. Okay, next. Expiration dating. So manufacturers determine it when they do stability testing on 3 different batches of the same drug. It gets a little more involved, next screen, gets a little more involved when a drug is repacked by a hospital and unit dose packaging. Because when you repack it, you change the expiration date of the drug. And that's converted to 1/2 the manufacturer's expiration date, or 6 months, whichever is less. Next. So for an example, if you use a repack date of 5/31/21, which is when you repack the drug, the expiration date on the bottle is 3/30/22. So the repacked expiration date would be 5 months or 10/31/21 because it was a 10-month date between the repack date and the expiration date on the bottle. So that's how you get 10/31. And you always try to use the beginning or the end of the month. You don't use the middle of the month as an expiration date. Next. Okay, NDC numbers. NDC means National Drug Code. It's usually 10 or 11 digits. And it's basically translated to the first group of numbers is the manufacturer. They have each one has their own code. The second set of numbers is the product code, individual to each product. And the last number is package size. Okay, next. Okay, returning medication. So pharmacies, be they retail or hospital, if they have a bottle of pills that's unopened and it's not being used, they can return it for credit. However, if it is open, they cannot return it. because it can't be reused once it's returned to the wholesaler. Next. So anything that can be returned due to expiration dating, or maybe they have too much inventory, or they ordered it by mistake. So the wholesalers will let them return it, but they do charge a restocking fee before they issue credit. So less credit. Next. Okay. In terms, and this is when a medication is not picked up by a patient in a retail pharmacy, it can be returned to stock. But if the patient picks it up and then decides to return it, it cannot be returned to stock or reused, because you never know what happened to the drug when it was out of the pharmacy. Next, about previous hospital unit dose packaging. If it's still in, the integrity is good, you can reuse it. Reverse distribution is where there's an outside company that comes into the pharmacy and takes care of all the returns and the expires, both non-controlled and controlled, and ships them back to the manufacturer or the DEA or whoever is going to dispose of them. And it can be dispensables or non-dispensables. Next. And I think this is the other Matt's slides. Because that was the end of mine.
Yep, that was it. I am so sorry. I think it was a later draft of everything. Was there, am I missing any more slides for you,
No.
Matt? Or that was it?
No, that was it, Robin.
Okay, excellent. Well, Matt, thank you so much for participating with this, and thank you so much for the information. We really do appreciate it. It's certainly going to help us for those who are tuning into us tonight for the PTCE. So I thank you again. So, ladies and gentlemen, we're 11 minutes outside of our call time at 7, but I think we can take a few questions. If you have any questions, please enter it into the chat so that way we can address it. I'll give a couple of minutes, like about 3 minutes or so people can formulate questions, place it there. One of our pharmacy technician executive committee members, Krista Clay, is actually on the line facilitating those questions. So by all means, shoot us a question. There are no stupid questions here. This is a safe virtual space. So trust me when I say, please ask a question. I feel like I should also have the Jeopardy theme song playing in the background. That would have been cute. Okay, we'll give it another minute. Please note, ladies and gentlemen, and I just want to say a special thank you, is that a great majority of the programming done today and last week was conducted by pharmacists. One beauty of being a pharmacy technician is seeing allyship. And one of the things, a part of being a NYCSHP and even looking at other chapters across of New York State is seeing that pharmacists are allying to be a resource for pharmacy technicians and to help the pharmacy technician profession advance. That has been one of the beauties of working with NYCSHP this past year or so that I've been able to experience. So I strongly encourage, if you ever get to see these people in person, or if you want to hit them up on whatever LinkedIn platform, whatever it may be, please say thank you. It is deeply, deeply appreciated to have pharmacists want to help. This is all volunteer. They took the time out of their hands to create these slides, to help us out, to create this programming. So for me, as the chair of the Pharmacy Technician Executive Committee for NYCSHP, I thank every single one of you who has helped out and facilitate this. On the line today is our president for NYCSHP, which is Jamie. Jamie is our captain of the ship when it comes to this amazing chapter. She is a staunch advocate for pharmacy technician practice and is deeply passionate about it. My director at large, Matt, who presented earlier today, him too, a staunch advocate for pharmacy technician practice. And I would love to thank you guys. I'd love to thank you guys for tonight and being here. Just checking the chat right now.
And thank you, Rafael. I think you really helped pioneer this whole journey. This whole year was really great. I'm really proud of you. Really proud of everyone who participated and also helped plan this program. I actually had a question about planning to take the test. How long would you guys recommend someone to plan to study the material before they take the test? And like, what's the timeline you would kind of map out for someone who is looking to get certified?
Excellent. That's a perfect question. I always like to tell a lot of the technicians that I've worked with in the past that you always set a date. So that way it helps prepare. I always like to say, set a date for at least a year and a half. Oh, no, excuse me, not a year and a half, a month and a half or so. Why did I say year and a half? I apologize. A month and a half. That way it gives you enough time to do a quick evaluation of what you have, of what knowledge you already have. So taking some practice PTCEs. Once you've taken a practice PTCE, then what we can do is you can sit there and look at what your strengths and weaknesses are. Okay, you know brands and generics. I don't have to focus on that, but I'm not strong in law, so I have to focus on that. I don't know anything about sterile compounding, but I know plenty about non-sterile compounding. So it's evaluating that so that way you can focus on these dedicated topics. In addition to that is also trying to help out, trying to find people within your network to help ask questions with. The beauty and the one thing I always tell every pharmacy technician is don't discount your pharmacists. Our pharmacists that we work with have gone through years of schooling. Some of them gone through a PGY1 and a PGY2. So they have a wealth of knowledge and know the topics pretty well, especially when it comes to pharmacology. So I would strongly encourage, if you have questions that can't be answered by a textbook, I'm the type of person that I hate reading textbooks. YouTube is a great resource for me, but it's not like there's a lot of available YouTube channels on this topic. The next best source will be your pharmacist. Go to them. There has to be a pharmacist that you work with very closely that can explain this, especially when it comes to the pharmacology stuff. And if they can't explain the pharmacology stuff, I'm sure there's a student or an intern that's around that can also help you with this. So I would say a month and a half at least to study and review. And keep in mind, when it comes to the PTCE, there is some preliminary things that you need to do before you actually take the exam. So look that up. NHA, the NHA exam or the CPhT also requires some pre-registration things that need to be taken care of. So I strongly recommend that you look into this. Now, if you're a pharmacy technician that's on the line right now that happens to work for an institution, please ask your administration, when is the deadline for you to take this? Many institutions across the state of New York are requiring pharmacy technicians to be certified so that way they can be certified and registered with the state of New York. So I strongly encourage everybody, 1, set a deadline. 2, start taking practice exams. 3, find out what your weaknesses and strengths are when it comes to the subject matter. And 4, find a pharmacist that you can actually lean on and to talk to, or at least try to help explain stuff to. If not a pharmacist, another technician, or even a pharmacy intern. So please, for some takeaways, that will definitely be it. I think we have a question in the chat. Will the slides from both CE presentations be available? I believe the correct answer is yes, both will be available.
Yes, I can confirm that. Yeah, because the state, they save the slides and they post on the website along with the audio.
Yep. So yes, it will be there. Again, so we're coming up on 7:18. I want to be respectful of everybody's time. So again, one last thank you to everybody that has participated. I want to thank everybody who's that joined us tonight. And again, those codes for tonight, we have pharmacists. Your code is risk. For pharmacy technicians, your code is hazard. I thank you all for joining me tonight and the rest of our amazing crew that got this all together. Have a great night, be safe, and good luck on your exam. We really, really, really hope you all pass. Please, 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 please study hard. You're gonna do this, you got this. So go out, study, make change. Have a great night, everyone.
Thank you, everyone. Have a great night and good luck.